What is type 2 diabetes? Today we're going to discuss type 2 diabetes from a kind of comprehensive perspective. We'll begin by discussing how the body regulates our blood glucose levels. We'll talk about type 2 diabetes and what are kind of the hallmarks of the disease. We'll discuss how type 2 diabetes develops. Moving on, we'll discuss signs and symptoms of type 2 diabetes as well as risk factors for the disease. Then we'll move on to diagnosis of type 2 diabetes, as well as management and remission of the disease, and how you can manage and reverse your type 2 diabetes. Before we dive into the kind of underlying causes of type 2 diabetes, what it is, what we see when it happens, it's important for me to kind of give you a brief bit of my journey with respect to type 2 diabetes. I do have a pretty strong family history of type 2 diabetes on my father's side. At the age of 29 years old, I was diagnosed as pre-diabetic. 2 consecutive fasting blood glucose levels over 110 milligrams per deciliter, and that's actually above the criteria. The criteria is actually 100 milligrams to 124 milligrams per deciliter, so I was well within that range. My hemoglobin A1C was 5.9%, which is above the target of hemoglobin A1C, which is 5.7%. For those of you not in the know, hemoglobin A1C is effectively a 3-month average of your blood glucose levels. And my triglycerides were hovering around the 150s. The first one was around 147, and then it moved up into the 150s. 150 is considered the cutoff for healthy triglyceride levels. Anything above 150 milligrams per deciliter is considered hypertriglyceridemia. I'd argue that it probably is even lower than that, probably closer to 100 or 125. I initially addressed this with my paleo low carb diet. Worked great. I lost weight, went from 230 pounds to 190 pounds in, I don't know, I'd say about 6 to 9 months. This managed my blood glucose very well. My hemoglobin A1C turned around. However, kind of deep within this journey, I decided to kind of see what would happen if I gave myself an oral glucose tolerance test, which is effectively just consuming 75 grams of a glucose drink and measuring your blood glucose levels every 30 minutes for 2 hours to see how I responded to this glycemic load. I failed it miserably multiple times. I tried it with many of the foods that I like to eat, and every time I ate these kind of foods that weren't necessarily low carb, my blood glucose levels spiked. So I could tell that something was going on here, that while I was managing my blood glucose levels very well, I really wouldn't consider this reversal of type 2 diabetes because I was still not tolerating carbohydrates very well. And there is a reason for this that we're going to go into in deeper discussion later on in the video. So the low carb paleo diet worked well for me, but I did notice based on this oral glucose tolerance test that when I was consuming carbs, my blood glucose levels were going way out of range. And so what would happen is, every 3 months I would measure my hemoglobin A1C levels, and some months it was very, very good, and some months it was not very good. And this obviously lined up with me consuming more carbohydrates during certain periods of the year. Generally speaking, I would guess that this was, mostly a factor of me kind of jumping into the carbs during, the holidays, Christmas, and at the beginning of the summer as well. And so I wasn't really interested in simply avoiding carbohydrates to keep my blood glucose levels better. I was more looking at making my body more tolerant to carbohydrate, making my insulin sensitivity better. So I realized that this low carb just wasn't working well for me. I think generally speaking, these low carb diets work well for a small number of people. Most other people, there's going to be some regression to the mean. The data kind of shows that whether you're going low carb, low cal, doesn't matter. Over the long term, after 2 years, most people are going to fail on a diet, and there's really no difference between who's sticking to the diet percentage-wise after 2 years. So I decided I had to find a dietary pattern that worked better for me, and this dietary pattern included carbohydrate, which up until this point I was under the impression that the best way to do it was with a low-carb diet, but there's quite a bit of evidence piling up, discussions in low-carb communities that when you go low-carb for prolonged periods of time, you induced a state of insulin resistance, which they termed physiological insulin resistance, and that it's actually just the way the body responds to a low carbohydrate diet. Believe that's 100% true. I just knew that I was not going to stick to a low carbohydrate diet long term, and that it was in my better interest to find a way that worked better for me. So that way turned out to be actually fairly high in carbohydrate. I consume certainly over 250, probably over 300 grams of carbohydrate a day. And I've been doing that since probably 2016, 2017. My A1C has never ticked above 5.0 since then. My most recent one, which I took on Monday, which was 6 days ago at the end of March, my most recent hemoglobin A1C was 4.7%. For those of you not in the know, this means that my 3-month average blood glucose levels was 90 milligrams per deciliter. That is my 3-month average. That's not my 3-month average of fasting. In other words, my blood glucose average, whether I'm eating, sleeping, consuming carbohydrates, exercising, is at 90 milligrams per deciliter. For those of you in Europe, that's 5.0 millimolars per liter. I recently did the Precision Health Report cardiometabolic assessment, and my lipoprotein insulin resistance was 20. This is out of 100. This is below what the chart really shows. The chart shows 30 to 100. This is excellent insulin sensitivity. I follow a bunch of people who are carnivore, a bunch of people who are low carb, and I have not seen anybody who has had a lower LPIR than 20. My triglycerides are always less than 45 milligrams per deciliter, which I think is great. You'll learn why that's important in a moment. And eating carbs really doesn't budge my blood glucose levels to an extent. If I ate an entire cheesecake or an entire half gallon of ice cream, my blood glucose would not be level. But what I normally eat at a normal amount of time, my blood glucose levels will go up and come down within that 2-hour period and will not qualify as impaired glucose tolerance based on the oral glucose tolerance test, which we'll discuss in a moment. So let's dive into blood glucose control basics. What we're looking at primarily, the things that regulate blood glucose levels. We're talking about the liver, pancreas, muscle, intestine, adipose tissue or body fat, and the kidney. We don't really need to discuss the kidney too much. We're going to start, we'll put our intestines right around here. So when you consume carbohydrate, this increases your blood glucose levels. And what happens is this blood glucose circulates to the pancreas. The pancreas identifies this glucose and secretes insulin. What insulin does is it tells insulin sensitive tissues such as the muscle, liver, and fat to pull glucose from the blood, and this lowers your blood glucose levels. It stimulates glycogen formation in the liver so that the liver is kind of a central regulator of blood glucose levels. It stores blood glucose levels, blood glycogen to kind of release glucose into the bloodstream. The storage form of glucose is glycogen. You store it in your liver and your muscles as well as other tissues as well, but those are the primary depots of stored glucose as glycogen. And what happens is when your blood glucose levels begin to drop, you get low blood sugar. This causes the pancreas to secrete another hormone called glucagon. Glucagon goes to the liver, tells the liver, hey, we are experiencing lower blood glucose levels. Release some of your stored glycogen. When it does this, glycogen is broken up, turned into glucose. The glucose enters the bloodstream and raises your blood glucose levels. This is the basic way that your body regulates your blood glucose levels. So just to kind of sum up, consume carbohydrate. Carbohydrate gets broken down into glucose. Glucose gets absorbed into the bloodstream, increases your blood glucose levels, causes insulin to be secreted by the pancreas. Insulin tells cells that are sensitive to insulin to pull glucose out of the bloodstream to bring that blood glucose down. Then, when we are in a period of fasting, our blood glucose levels begin to drop. When our blood glucose levels begin to drop, this tells the pancreas, hey, we need more glucose. Pancreas secretes glucagon, which goes to the liver. Liver pumps out glucose to raise blood glucose levels. Type 2 diabetes causes a situation to mess this entire system up, which we will discuss next. Now, what do we see in type 2 diabetes? We see what is a triumvirate of effectively energy excess. We see hyperinsulinemia, which is high insulin levels, hyperglycemia, which is high blood glucose levels, and hypertriglyceridemia, which is high triglyceride levels. We also tend to see some defects in lipid or fat metabolism. You'll generally see increases in LDL cholesterol, maybe decreases in HDL cholesterol. But primarily what most people think of with respect to type 2 diabetes is the high blood glucose levels. And the reasoning behind this isn't necessarily that hyperglycemia is the worst effect here. Hyperinsulinemia and hypertriglyceridemia are also very, very bad for you. The reason blood glucose levels are more commonly associated with type 2 diabetes is that they're very easy to measure. You can measure them at home, and it's kind of a very simple cause and effect. You can do certain things and lower your blood glucose levels. Things like insulin and triglycerides are simply not measured at home. It's harder to measure them. You have to send it out to a lab, and most efforts are put towards measuring blood glucose levels. But that does not mean that having regular blood glucose levels isn't necessarily good. Having regular blood glucose levels with high insulin and high triglycerides is bad as well. You can't just kind of, you don't really just want to kind of game the system by lowering your blood glucose levels. You want all three of these things to come down. Type 2 diabetes, the patient does make insulin. They're insulin independent. They don't need to take insulin, at least at the very beginning of the disease. But what happens is receptors on the cells of the insulin sensitive tissues decrease it. And this makes those cells insulin resistant. So going back to our model before, what happens is blood glucose levels increase. The pancreas notices that these blood glucose levels increase, so it secretes insulin, and this insulin circulates, but it does not cause the muscle, the fat, or the liver to take in more glucose, so blood glucose levels stay high. The pancreas notices this, increases insulin even more, and so you have high insulin levels above what is physiologically normal. What's interesting about this as well is that these cells that are secreting the insulin are called beta cells, but the cells that secrete glucagon by the pancreas are called alpha cells. And what happens is these also become insulin resistant. Insulin will generally shut down glucagon release, but what happens when these alpha cells become insulin resistant is that we are getting too much glucagon at the same time. So in addition to your cells not listening to insulin and glucose circulating more, we have high glucagon levels as well, which are telling the liver to dump glucose into the blood to raise blood glucose levels. So in addition to your cells not pulling glucose out, you have the pancreas telling the liver to make more glucose to dump into the blood because glucagon levels are high as well. Now, type 2 diabetes, there are some factors that kind of increase our risk for it. The older we get, generally speaking, we become more insulin resistant and our risk of type 2 diabetes goes up. There are genes related to type 2 diabetes. The problem is most people have these genes. They're often referred to as thrifty genes, and the belief is that we evolved to have these thrifty genes. Ethnicity, non-whites are generally, at least African Americans and Latinos, are generally at an increased risk. And lifestyle is one of the primary, if not the primary driver of the disease. And what we're looking at through this whole thing is excess energy availability compared to energy need as the key driver. In other words, you're consuming more energy than you need, and what's happening is you're taking this energy and shunning it into fat cells, and over time you meet a certain threshold which causes you to deposit fat in places where it's not supposed to be. This idea that chronic overfeeding, as well as other factors driving fat accumulation to the point of exceeding our ability to store excess energy as body fat and dumping it into the liver and pancreas is known as the twin cycle hypothesis of type 2 diabetes, and these results have been reproduced over and over again. Evidence has shown that when you reduce fat in the liver and the pancreas, that you get restoration of normal blood glucose control. This has all been shown multiple times over and over again. So this is the predominant theory of how type 2 diabetes develops. And the way it works is that a chronic positive calorie balance, meaning you're not simply just eating too many calories in a single day, but chronically doing it over and over and over again, coupled with pre-existing muscle insulin resistance, causing us to take excess energy stored into our body fat. We then eventually meet what is a personal fat threshold. We can only put so much body fat on, and this is genetically predetermined, which explains why you can have lean people with type 2 diabetes as well as morbidly obese people with it as well. So you meet this personal fat threshold. The energy has to go somewhere, so we initially begin dumping it into the liver. Now, before we move on, it's important to point out that there are some acute things that we can do that can reverse pre-existing muscle insulin resistance. For example, sleep deprivation drives muscle insulin resistance. So if we can get better sleep, we can kind of work on that avenue, as well as being more physically active. We'll discuss that, but generally speaking, the more sedentary you are, the more insulin resistant your muscles will be. So you're just going to kind of dump excess energy into the body fat stores until you meet your genetically predetermined personal fat threshold. Then the excess energy is going to circulate and get deposited into the liver. When this happens, we get something that's very similar to what happens in body fat stores. With body fat stores, as they fill up more and more, they begin to be infiltrated by immune cells. These immune cells induce inflammation. You get all these inflammatory cytokines, and that can induce tissue insulin resistance. Same thing happens into the liver. The liver is now resistant to the effects of insulin. Insulin tells the liver to stop dumping glucose into the blood. On top of that, you get increased glucagon release, which is telling the liver to put out more blood glucose. As a result of this, the pancreas senses this high blood glucose levels and pumps out more insulin. And this kind of cycles through until we've, begun pumping in too much fat into the liver. This excess energy then makes its way into the pancreas. We begin depositing fat into the pancreas, and in the same way that this excess fat impairs liver regulation of blood glucose, it does the same thing to the pancreas. So initially what we're going to see are cells in the pancreas becoming more insulin resistant. That includes the alpha cells that secrete glucagon. So the pancreas, in addition to pumping out too much insulin, is pumping out too much glucagon. Now that the liver is insulin resistant, this kind of insulin resistance, the liver not listening to insulin, causes the liver to dump glucose into the blood. At the same time, glucagon is telling the liver to put glucose out into the blood. We elevate blood glucose levels further. And it's just really interesting that these alpha cells, at this point, the ones pumping out glucagon, are insulin resistant as well. Over time, this causes the pancreas to decrease its insulin response to ingested glucose. This causes a further rise in postprandial glucose. Postprandial glucose is just simply the post-meal after you eat blood glucose levels. So on top of your liver just pumping out too much glucose, you are going to have a decreased insulin response to meals, and this is just going to cause chronic hyperglycemia, hyperinsulinemia, till the point that your pancreas stops working, and then insulin levels are going to go down, and we're going to have increased hypertriglyceridemia. When we look at hyperglycemia and hypertriglyceridemia, when we have both of these at the same time, it is clearly due to chronic energy excess. If we only had hyperglycemia, we wouldn't see, this would effectively be that the problem is simply just too much glucose in the system, but it's too much energy in the system. Those excess triglycerides are getting dumped in the liver and into the pancreas, and they're interfering with the functions of both. There are a number of signs and symptoms of type 2 diabetes, and it's important to point out that you do not have to move to full-blown type 2 diabetes to experience these symptoms. You can experience them in prediabetes, because during prediabetes, you are going to experience hyperinsulinemia, hyperglycemia, and hypertriglyceridemia, and these are at least part of the things causing the symptomology of type 2 diabetes. So you will experience something such as polyuria, which is excessive urination, and polydipsia, which is excessive thirst. These two things are are related. It's the water balance. When you pee too much, you lose too much water, so you are thirsty more. You also experience polyphagia, which just means that you overeat, and which is clearly why we are seeing things. We are seeing these accumulation of fat. There's excessive calorie intake, and so part of the problem with type 2 diabetes, it's a progressive condition. Some of the symptoms actually promote it, and one of those is that you just kind of chronically feel hunger. This may be related to leptin resistance, which leptin is a signal that tells you to stop eating, and what happens is when you have leptin resistance, you don't get that signal, you eat too much. That is polyphagia. Unexplained weight loss, this is generally going to come later on after your body is just not capable of storing body fat and it's not really listening to insulin. That's more of a unexplained weight loss is more of a condition or symptom that happens deeper into the type 2 diabetes diagnosis. Fatigue, irritability, blurred vision, frequent infections because the immune system is impaired, because you have all of these immune cells infiltrating fat and adipose tissue and causing inflammation. Acanthosis nigricans, which is the image here, it's kind of a browning of the skin, particularly in creases. And lactic acidosis and ketoacidosis, this is bad. Effectively, this means that the blood and tissues are becoming too acidic. In addition to the signs and symptoms that occur as type 2 diabetes is developing, there are consequences of poorly managed diabetes that happen over the long term. Things like vascular disease, effectively the small blood vessels supplying blood to your organs and tissues get blocked up with plaque. This decreases circulation, and you can experience amputation of your fingers or toes. You can also see impaired function of your organs. They're all supplied by small blood vessels. Blood vessels get progressively smaller as they get to the tissues. Additionally, you can this kind of vascular disease will also manifest itself in heart disease as well as erectile dysfunction. Those are small blood vessels feeding into the erectile tissue in the penis. Hypertension, this is created by vascular disease. Retinopathy, which means these small vessels that are supplying the eye are now not getting oxygen and blood to the eye. This is what we see over here, diabetic retinopathy. This is normal vision. This is what happens in diabetic retinopathy. Again, effectively caused by poor blood flow to the small vessels supplying the eye. Neuropathy, same deal, damage to the small blood vessels supplying the nerves. Nephropathy, this is kidney disease. This is damage to the kidney, the nephron specifically, and this is because it's not getting the blood supply that it needs. Alzheimer's disease, which is often referred to as type 3 diabetes. This is probably not simply due to vascular disease. Vascular disease is certainly playing a role, but there are other factors at play as well. And there are a number of gut motility disorders as well as general gut disorders that can occur. This is not only caused by the vascular disease definitely drives it, but there are other factors related to this, things related to the microbiome, things related to the nerves, the enteric nerves. You can get an enteric neuropathy, which is damage to these nerves that regulate motility in the gut, but these nerves also regulate hormone secretion and other things going on with the gut as well. There are a number of risk factors for type 2 diabetes. As I mentioned, family history is important. This is simply not referring to genes. There is a heavy genetic component to this, but most people tend to have these genes. But also things you may kind of learn from your family, behaviors that you learn from your family. So family history is kind of a combined genes and environment issue. Being African American, Latino, Alaskan American, Pacific Islander, Asian American, Native American, effectively non-white, these people generally have a higher risk for type 2 diabetes. Being older than 45 years old, a lot of that can be driven by behavior, increased feeding, being more sedentary than you were when you were younger. Being overweight and obese, clearly in a disease of energy excess, being overweight or obese is going to increase your risk. Being sedentary, because being sedentary increases your risk for muscular insulin resistance, which can help kind of drive this twin cycle. Having other components of the metabolic syndrome, which are hypertension, the hyperlipidemia, problems with like your LDL, HDL, or triglycerides, having central adiposity, which means effectively having a higher waist circumference, effectively the things that predispose us to all disease. These are risk factors for type 2 diabetes. These are associations. So clearly, is type 2 diabetes causing the increased waist circumference, or is the increased waist circumference causing the type 2 diabetes? Risk factors. These are saying that you are at a higher risk. So it's not necessarily that things like, say, high LDL cholesterol cause type 2 diabetes. They're more a component of the disease. History of cardiovascular disease or just stroke, same type of deal. Type 2 diabetes can cause cardiovascular disease, so it's not necessarily that your cardiovascular disease is driving type 2 diabetes. The idea is that if you have cardiovascular disease, you also have potentially type 2 diabetes. And PCOS, which is polycystic ovarian syndrome. Interestingly enough, it seems that polycystic ovarian syndrome may be caused by insulin resistance, increasing androgens in females. So if you have PCOS, there's the potential for a higher risk of type 2 diabetes. How do we diagnose type 2 diabetes? Well, we have three ways that we do this. I mentioned hemoglobin A1C, which is effectively a 3-month average blood glucose. If you have hemoglobin A1C of 5.7 to 6.4, you are said to have pre-diabetes. If you are over 6.4%, you are said to have overt type 2 diabetes. And it's kind of incorrect to say type 2 diabetes. This is also how we diagnose type 1 diabetes as well. So here we use DM, which is diabetes mellitus, but we're kind of focusing on type 2 diabetes here, so we're going to kind of stick to that. Your fasting blood glucose levels, which are not great, not a great marker. They are very very easy to affect. You can have high fasting blood glucose levels, and you can have a low hemoglobin A1C. For example, my last fasting blood glucose level was 101. I got bad sleep the night before, but my hemoglobin A1C was 4.7. So fasting blood glucose is just not a great marker. This was the marker we previously used most because it's much more accessible. And people with pre-diabetes have a fasting blood glucose level of 100 to 125 milligrams per deciliter. And people with overt diabetes have a fasting blood glucose level of 125 milligrams per deciliter. And it's important to point out that having one measurement at this level doesn't mean anything. It could be a measurement error. You would want to see a pattern of 2 or more fasting blood glucose tests showing that you have elevated fasting blood glucose. And finally, we have an oral glucose tolerance test, and that's what we see the graph here. So what you do is you get a fasting blood glucose level. Then you consume 75 milligrams of dextrose or glucose, and then you follow your blood glucose level over time to see what happens. A normal person will start, somewhere between 90 and 100 milligrams per deciliter. They'll have a small rise, which can go up to 140-ish, and then you'll see a small decline. And what we really want to see is at 2 hours, we want to see your blood glucose levels come down to or below what your fasting levels were. And with a type 2 diabetic, we just see chronic elevation and it stays elevated. We have here this 200 milligrams per deciliter marker, which is probably, this is one of the measures. Honestly, above 160 is not great and probably indicative of impaired glucose tolerance. So you really want to kind of keep it down below that, the max down below that 140, and you certainly would want it back to normal after 2 hours. A type 2 diabetic does not experience that. We previously believed that type 2 diabetes was a progressive disease, meaning if you got prediabetes, eventually you would get type 2 diabetes, and as you had type 2 diabetes for longer periods of time, you would stop making insulin. You would effectively be, quote unquote, wearing out your pancreas so that it does not produce insulin, and then you would become dependent on insulin injections to manage your blood glucose levels. However, we now know that lifestyle can manage and reverse type 2 diabetes. One of the more popular ways that people are doing this nowadays is a low-carb diet. Effectively, what you're doing with a low-carb diet is you're decreasing the amount of glucose dumped into your blood when you eat by decreasing carbohydrates, which are broken down into glucose. So with a low carb diet, you can establish rapid glycemic control, meaning your blood glucose levels come into the normal range. The problem is a long-term low carbohydrate diet can actually create poorer glycemic control if you decide you want to eat carbohydrates again, whether this is sporadically on the weekends or here or there for holidays, or you just decide, you know what, I think that I'd kind of like to increase my carbohydrate intake. You will see that as you kind of increase your carbohydrate intake, that your blood glucose levels are going to go back into the pre-diabetic and potentially even diabetic range. This happens even with weight loss. This seems to be not necessarily a bug of long-term carbohydrates diets rather than a feature. Basically, the body is responding to low carbohydrate intake by not secreting insulin rapid enough. And this takes some time to kind of adjust to. So if you decide you want to go low carb and you get better glycemic control, but then later on say you want to reintroduce carbohydrates, you can actually have impaired glycemic control for a prolonged period of time. If you do couple this with weight loss, in other words, the low carb diet also causes weight loss, you should be able to reestablish glycemic control. It's just going to take you some time. Your body's not used to getting carbohydrates. So now, after having switched to a low carb diet to help manage your diabetes, you decide, yeah, kind of want carbs in my diet. You're going to have to change again, and you're going to have to slowly ramp up the carbohydrate intake to find what works for you, both based on your lifestyle as well as genetic factors related to it. But the question is this kind of remission of type 2 diabetes? It's certainly excellent management of blood glucose levels, but the question is this remission? So let's kind of look at this. Type 2 diabetes is effectively an intolerance to glucose. So when you eat carbohydrates, this increases your blood glucose levels. So you're removing the source of intolerance. You're removing the carbohydrates from your diet, which is great. Hyperglycemia is bad for you. But let's take a look at this kind of in terms of an egg allergy. Like, let's say you have an egg allergy and you stop eating eggs. Have you put your egg allergy into remission? No, you're still intolerant to eggs, and when you eat eggs, you'll have an allergic reaction. I feel in the same way, a low carbohydrate diet is managing blood glucose levels. In my opinion, there's no better acute way to rapidly bring your blood glucose levels under control. But this is not remission of type 2 diabetes. Unless it's coupled with weight loss and you put in the time to kind of reestablish carbohydrate intolerance, which can take many, many weeks. And the study referenced above, it took 10 weeks and they still were not back to normal blood glucose regulation. What we see is, though, that fat loss leads to actual remission. Once the liver and pancreatic fat are lost, the liver and pancreas are allowed to now work properly to regulate blood glucose levels. The liver puts out the appropriate amount when you consume carbohydrate in your diet, and that is absorbed in the blood as glucose. The pancreas responds in kind, increases insulin levels. Muscle cells, adipose tissue, and the liver are insulin sensitive, so they will actually pull the glucose out of the blood, and you have normal glycemia, you have normal insulin levels, and you do not have hypertriglyceridemia. And the more weight you lose, this actually creates a buffer. So you don't just want to lose the amount of fat that comes out of your liver and your pancreas. You want to lose enough fat so that if you decide, hey, I want to have some cake, I want to enjoy the holidays, you want to have some body fat space to pack on body fat before you start putting it into your liver and pancreas. Generally speaking, to begin seeing normal glycemia in most people, we're looking at a 5 to 10% weight loss that's necessary. Clearly, if you have more than this in your liver and pancreas, it's going to require more. On average, the 5 to 10% can help you reestablish better blood glucose levels, which is what makes the study above that I referenced even kind of more interesting, that even when you lose 15% of your weight and a non-diabetic, a long-term low carbohydrate diet can create poor glycemic control that takes a little while to reestablish. I don't think that this is necessarily damaging unless you're going to begin jumping off your diet here and there and increasing your carbohydrate intake. When I kind of initially managed my blood glucose levels by going low carb paleo, this is what I experienced. Any OGTT, oral glucose tolerance test that I took caused a bad result. Anytime I ate something like, say, granola or bread or anything like that caused my blood glucose levels to go through the roof. Now that doesn't happen. I've brought my liver and pancreatic fat stores into check, and I'm well below my personal fat threshold. threshold. At my highest, I was around 236 pounds. I'm currently 185 pounds. I'm very physically active, which you'll learn physical activity and exercise and strength training are all ways to help you better manage your blood glucose levels and put type 2 diabetes into remission. There are also drug treatments for type 2 diabetes. Clearly, when you get to the point that your pancreas just is not putting out insulin, you may eventually require exogenous insulin injections. There's also metformin for type 2 diabetics. This metformin decreases hepatic glucose output and it increases insulin sensitivity throughout the body. Other drugs for type 2 diabetes include incretins, which are hormones that help regulate insulin output and insulin sensitivity, such as Januvia. Drugs that increase insulin production by you, not by taking injections such as Victoza, and insulin sensitizing drugs, which causes the cells in your body to become more sensitive to insulin, such as Avandia. These are very useful at the very, very beginning of type 2 diabetes, and if you're simply not going to make the changes necessary to manage or reverse type 2 diabetes, you should certainly consider these drugs. Ultimately, doing the lifestyle things is the most effective and safest way. There's really not a side effect to losing weight and being more physically active, whereas there are potential side effects to these drugs. That's not to say that you should not use them. They're very useful to help establish glycemic control and with the hopes that you will make the positive lifestyle choices to manage and potentially even reverse your type 2 diabetes. Let's assume you've gone to the doctor, whether you've gone to the doctor before and he's told you you're pre-diabetic and now you're type 2 diabetic, or this is the first time you've been to the doctor in a long time. They say, hey, you got pre-diabetes, or they say type 2 diabetes. The first step is managing your type 2 diabetes. This is stage one. The first thing, you want to get your blood glucose under control, your high triglycerides under control, your high insulin under control. One of the first things you could do that you're actually going to feel better is to improve your sleep and circadian rhythms. Poor sleep impairs insulin sensitivity. Things like picking a bedtime and sticking to it, going to bed and waking up at the same time, being physically active through the day, things of that nature can all help improve your sleep, not being exposed to light at night, getting more light exposure during the day. You really want to improve your sleep. This is more of an acute effect, but this, once you establish good sleep, you will see improvements in insulin sensitivity. This can help manage your symptoms of type 2 diabetes. Increasing your physical activity. Now, it's important to point out physical activity is not the same as exercise. Exercise is important too. With physical activity, we're talking about going for walks and things of that nature, not being in a seated position and doing nothing. You want to get up, move around. Increasing your physical activity will cause your muscles to use more glucose. This will cause your liver storage of glucose to go down, your muscle storage of glucose to go down. That way, when you consume carbohydrates, there's space for them to go in the liver, muscle, and adipose tissue. Taking a walk 30 minutes after meals, a 15 to 20 minute walk after meals can help pull your postprandial or post-meal blood glucose levels down. So eat, wait 30 minutes, go for a 20-minute walk after each meal. Strength training is also important. When we strength train, we increase the amount of glucose that our muscles can store as glycogen. In addition to, when you're using those muscles, you're burning the glucose that's stored as glycogen that is in there. Long-term adaptation to training cause your muscles to increase the amount of insulin they can, or glucose that they can store. Importantly, when we look at what tissues can store glucose, we see the liver can store between 100 and 150 grams of glucose, but throughout your entire body, your muscle can store 300, 400, and in some endurance trained athletes, you can get over 400 grams of glucose storage in your muscle. So you see, muscle glycogen storage is important. We can increase that with strength training. It causes our muscles to pull in more glucose, and it causes our muscles' ability to store more glucose to increase. And a low-carb diet is great if it fits for you. It may not be for you. As I've mentioned multiple times previously in this video, as well as multiple times in the blog, low-carbohydrate diets are no more effective in the long term than low-calorie diets. People just don't stick to diets. But the people who it does, it is life-transforming. Even if it's 5 or 10% of the people who take on a low-carbohydrate diet, if that succeed over 2 years or more, that is huge for these people. So if a low carb diet is right for you, You can use it initially to help manage your blood glucose levels, and you can use it in the long term provided you stick to it. Now we can move on to the main event. You've increased your physical activity, you've undertaken exercise, your strength training, you're getting good sleep. Now, how do we put type 2 diabetes into remission? How do we reverse it? It is critical to find a long-term dietary strategy or eating pattern that's right for you. This will lead to a healthy energy intake. What's a healthy energy intake? This is an energy intake that you eat day in and day out that leads you to become a healthy weight. For most people, the BMI charts are right on. I generally carry a little more muscle than the average person. The BMI charts are right on for me. But if you are kind of one of these people that just puts on muscle very easily or is just generally more muscular, BMI is really not a number you want to look at. You'll know based on your body fat if you're at a healthy weight. Generally speaking, for a man, we're talking about 10 to 20 or 10 to 12% body fat. And a woman, you're looking at around 20% or a little more. You certainly don't want to bring your body fat levels down to a level where you're no longer, experiencing your menstrual cycle. So this is going to vary between individuals. So we want to find this long-term dietary and eating pattern that's right for you. It's going to reduce your binging. You're going to feel satisfied with what you eat. You're not going to feel like you're depriving yourself of things. There are so many options to include here. You can do standard calorie in, calorie out. You can do low carb. You can do time restricted eating. You can do intermittent fasting. You can do a Mediterranean diet. You can do a ketogenic diet. For some people, they find a carnivore diet is great for them. In terms of finding a healthy weight and managing type 2 diabetes, the most important thing is that you get yourself to a healthy weight. So whatever works for you. There are proponents who think that a low carb diet isn't great. There are people who think a vegan diet isn't great. And the truth of the matter is, as humans, we're very adaptable to diet. So what's most important is that you find an eating pattern that makes you feel satisfied, that you can easily follow. And whether that's low carb, keto, calories in, calories out, time restricted eating, intermittent fasting, a Mediterranean, or whatever, that's what works for you. I will tell you, for me, I do time restricted eating. I don't necessarily do calories in, calories out, but since I've kind of been in the industry for like 25 years now, I know how many calories are in things, and I'll discuss at the end kind of some of the tricks that I use to kind of not have to count calories, carbs, or anything, just kind of stick to my feeding fasting window. One of the most important things you can do is avoiding a Western diet. Western diet is high in processed food and energy intake. You want to eat foods that make you feel full. A Western diet, high processed foods. Processed foods don't make you feel full at all. They kind of override your satiety signals, so you eat more of them. So limiting these types of processed foods such as chips, cereals, and other processed foods or sweets is a kind of a really important thing to do. That doesn't mean you cannot eat them. They just should not be a major component of your diet. If you want to go into a low carb diet, is a low carb diet right for you? And you can replace low carb diet. Same with Mediterranean diet. Is a Mediterranean diet right for you? Is calories in, calories out right for you? Will you stick to it? If you're doing low carb, can you stick to low carb? If you're counting your calories, are you really going to count your calories? You're really going to kind of figure out how many calories you're burning? Do you want to reintroduce carbs? Do you want to stop counting calories? Do you want to eventually move from time restricted eating to eating whenever you want? Are you willing to put in the effort it takes to change? And if you do make that change and you have to take a change again, are you willing to do that? Most people are not going to change once, so it's much more difficult for them to change twice. So if your idea is I'm going to use a low carb diet to get to my healthy weight and then change back, you have to keep in mind your blood glucose levels are going to kind of be out of whack for, up to 12 weeks, maybe even more. If you think you're going to, change, I'm going to start counting calories every single day, and then you're just going to stop doing that, chances are you're going to put your weight back on, and type 2 diabetes is going to be a problem for you again. With the Mediterranean diet and a lot of the omnivorous diets, are you willing to put in the effort to prepare your food? And then are you going to continue to do so over time? You're not just going to be able to stop doing that. If you stop doing that, if you stop preparing your food, you start eating out more, you start eating more processed prepared foods, you're going to go back to where you were. So whether you're talking about a low carb diet, calories in, calories out, whatever you do, it's got to be something you're willing to do that's easy for you and that you are not going to change. If you do decide to take a low carb diet as your acute approach to managing blood glucose levels. There's nothing to that. Just realize that reintroducing carbohydrates is going to take some time, and we'll definitely cover that in a video later on, some of the kind of tips and tricks to doing that. We'll close out this discussion giving you some ideas of things that I do, so maybe that these things can help you. One of the things that I do that is really important is creating targets to hit. I do not do this with my diet. I'm not interested in micromanaging my diet. I put in the effort up front. I found out a diet that works for me. I'll discuss in a moment kind of one of the ways that I make it so that I don't really have to pay too much attention to my diet. I create targets to hit, daily steps, weekly moderate to vigorous physical activity. So I generally shoot for around 12,000 steps a day. My moderate to vigorous physical activity, I try to get around 100 a day or 700 minutes a week. This is based on the activity minutes on the Fitbit, which may be different from other things. Ultimately, what I'm trying to do is I'm trying to get 60 minutes of moderate to vigorous physical activity every single day. And kind of the way that the Fitbit does that target seems to be about 100 active minutes. Strength train 4 times a week minimum. I stick to this. You don't have to necessarily pick 4 times a week. I like 4 times a week because I do believe that it makes me feel better. I also believe that it kind of increases the amount of glycogen storage so that I can eat more carbohydrate. It also empties out my glycogen storage so that there's space. I have a rigid sleep-wake schedule. I go to bed at 10 p.m. and wake up at 6 p.m. I do not change this weekly. Maybe once or twice a month I will stay up until 10:30, and I don't really ever sleep in, but this is basically, you're talking about 28 to 29 out of the 31 days a month I'm sticking to the same sleep-wake schedule. And I have a daily feeding window of 7 a.m. to 7 p.m. There is some wiggle room with this for me. At 7 a.m. I'm actually not eating. I consider drinking coffee as breaking my fast because it's going into my gut. I'm more focused with my time restricted eating on improving gut health. So at 7 a.m. I'm drinking coffee, and around 9:30 a.m. I'm drinking breakfast. So there is a little bit of wiggle room in this, but generally speaking, I do not eat after 7 p.m. And it's important to point out that these targets are hard targets. I absolutely have very little wiggle room. 7 p.m. end of my daily feeding window is only under situations where I'm celebrating somebody's birthday or we're going out to eat. Again, that does not happen often. It might happen quarterly. It rarely happens once or twice a month. Determining thresholds for ramping up your efforts. There is an argument out there, should people weigh themselves every day? I do weigh myself at least 4 or 5 times a week. I have a threshold that once I exceed, I ramp up my efforts. I increase my physical activity. I cut back on foods. For example, if I'm snacking here or there, adding extra foods into my diet. So I have a max weight of 190 pounds, and when I start ticking up above that, I start ramping up my efforts. I want my weight to be between 180 and 185, and if I let it go over 190, that just becomes much more difficult for me to manage. Create habits that promote consistency. This is kind of what I was talking about with my diet. I do not count calories. However, I eat the exact same thing for breakfast every day, and half of my lunch is the same thing every day. This creates a standard calorie intake for half of my daily food. My breakfast is my biggest meal. It's the same breakfast every day. It is a little over 700 calories. The half of my lunch is always a salad. And while some of the components do change, pretty much only the protein, it does create effectively the same number of calories every day. This gives me a combined intake at breakfast and half of lunch at around 1,200 calories. And then the other half of lunch is generally a leftover from dinner, and dinner, which is always my smallest meal, that changes. It's a protein, a starch, and some sort of non-starchy vegetable every single day. This is going to get me up to around 2,800 to 3,000 calories every day. Again, I do not count this. I have counted it before, but I'm not micromanaging my diet. I'm not weighing my food. I'm not, if I'm having something that's out of my diet, such as pretzels, I'm not counting out the number of pretzels I eat. I'm just sticking to a very, very strict, consistent breakfast and lunch protocol. That way I don't really have to count calories at all. Finally, I will say eat things that you like. I do eat things that I like. On the weekends, I do eat pizza. I do eat chicken wings. In fact, I ate both things yesterday. Every now and again, I will consume things I like, such as kettle cooked chips or ice cream, or things that you would consider these processed foods in a Western diet. They're just rare. I don't eat them every day. I eat them a couple times a week, and I don't take a cheat day. I don't say, okay, I can eat whatever I want from Friday after work until Sunday. I simply don't do that. That creates too much chaos. There's way too much variability there. I just allow myself to eat the things that I like. And generally speaking, when you create consistent habits, you'll generally tend to stick to those habits. So, having these habitual foods that I intake all throughout the week kind of creates patterns over a long period of time where I don't feel like I need to sit down and eat an entire pizza or cheesecake. So these are the things I do. These may or may not work for you. I hope they helped you. I hope you enjoyed this presentation. And I also hope that this gives you a greater understanding of what type 2 diabetes is, how you can manage it better, and how you can reverse it. Thank you very much for listening in. Take care.